I'm Dr. Melissa Wittman,
And I'm Chad.
and this is the Autistic Female.
How you doing today?
Good. It was a good Monday. I don't know, the morning went fast, like the flow of patients was great. Yeah, it was a good Monday. I feel pretty balanced. I've been doing a couple different things that I think are really helping. I'll probably share that on the next episode that I've been fairly consistent with that are just keeping me even more balanced, which has been really good.
That's great. So what are we going to talk about today?
So today we're going to talk about what does it look like when someone comes in my office specifically as an autistic female. So again, I see mainly pediatric brain injuries, some neurodevelopmental disorders. I mean, actually a lot of neurodevelopmental disorders. But I also, and I just had a new patient on Friday, so I'll kind of share that case because it's a really good example of what I see when an autistic female comes in who's undiagnosed, has been given other diagnoses, and what do I hear in the history? What do I see clinically? That kind of thing. And just a reminder, I'm not a psychologist. I'm not a psychiatrist. I do have a bachelor's in psychology. That helps a little bit. A, but I'm coming at it from a developmental neurological perspective. So that's my disclaimer that I'm not like diagnosing via the DSM criteria, which is kind of crap for females anyway. Needs to be revised, but
Love it.
that's
Yeah,
it.
you're appeasing my legalese from our other
I'm learning.
And for the record, I am wearing the blue blockers that we got into our little tiff about that we covered on.
It
So
looked good, which I think is why I'm letting it pass. Okay. So let's talk about this. So this is specifically for someone who is undiagnosed. Pretty much every woman that I've seen in my office or, even a teenager that's come in, either the parent or, the person themselves has at least thought, I wonder if I'm autistic. I think I might be autistic. And Friday was no different. So this was a teenager that came in and has been having anxiety and just a lot of other symptoms that can kind of be quantified as like she's just not getting by basically in life. She just feels like she's not living to the potential that she wants, that everything is harder than it needs to be, which I can totally relate to that. And so we clicked right away. I was really happy that I had her for her initial exam. That was really, really great because I was able to kind of throw some things out like, yeah, when you see a mess in your room, you just kind of are in a freeze state, right? Like it gets to a point where you just literally need less stuff around you. You can't function. And do you want to speak to that? What happens if our house is messy?
well, I actually was to say you love keeping lots of little like there's just a lot of little things everywhere. Like you're not a hoarder by any stretch of the imagination. The
No,
house
no,
is
I'm
very
very we
very
got flies in here.
but I wouldn't call it minimalist though either. There's, I'm even looking at your desk over there, right? There's like 3 crystals
I
on
mean,
that
I have
side, a
yeah.
couple Buddhas, there's a lamp, there's another lamp next to it.
To have
There's
the salt lamp.
yeah, there's just a
Yeah,
lot of lot
for
of
sure.
things,
Everything
yeah.
is very purposeful, which I think everything I keep is very purposeful. I might not mean it to you,
Dare
but
I say you have a chair with everything you could ever want
no,
next to the
I
chair?
actually don't.
That's an inside
I
joke,
don't.
sorry.
I don't. Yeah. So what can happen though, especially since we have kids. Before we had kids, that was really easy. I felt like I could keep things again, I wasn't a minimalist, but I really kept things clutter free for the most part in my adult life. Now, in college was a different story.
It wasn't terrible,
But when
but
I was living by myself, because I was learning so much. I was working for a chiropractor, working for a naturopath, learning all these different things. They'd give me these resources, and everything was still very much like on paper back then. So I had these like stacks of research papers and different things, and they made me really happy. But then there's a point where I'm so overwhelmed I can't function. And it was never like if you walked in, you would never were like, "Oh my gosh, like what the heck happened?" Because it was always clean, like, it's never like gross dirty, but I would just want to have research. It's one of my special interests to have all of that. So I'd want to keep all of that.
yeah, I think like our kitchen table in Florida when you were in school was a great example of that. Like our kitchen table
Yes.
was like your de facto desk, and it was
Textbooks.
just
Yes.
and it was like I
Uh-huh.
think a 4 or 6 person table, so it wasn't big, but it
Yeah, and
wasn't
like you
tiny.
and I could eat dinner at it.
Yeah, but it was like it had a lot of
For sure.
your school
for
But, I
sure.
mean, I also think that's kinda normal, but I know you're just describing yourself as, like, one of the things we talk about a lot is
Yeah.
you love your big paper calendar. You liked having, like, actual real
It's literally
notes.
called the big ass calendar.
Right. And I have everything digital. I
I
have,
can't do digital
right.
calendar, yeah.
And yeah, anyway, so I'm sorry to interrupt there.
So this patient comes in and that's a concern for her, and part of it, I got to give them my COVID theory, the theory that I presented, at in a previous episode, completely applied here. It was another person that it completely applied to. So she was kind of having these issues, an autistic female. Again, I'm not diagnosing her as a psychologist
Suspected,
or psychiatrist. Sure. But
alleged.
oh, okay. And no, I don't even know what
I'm
I was
sorry,
saying.
yeah.
You
So
my
you were
train of
saying
thought isn't
she
that
came
good.
in and you'd kinda were recognizing your COVID theory.
Right, and so I explained this to her, I explained this to mom, it completely makes sense. So she's someone that she's not in that, like, green light ventral vagal all the time where social engagement networks are on, she's not in that. She was already hovering in that fight or flight sympathetic state, and then COVID came, and where they lived and the way they did COVID was, like, complete lockdown, and she's the oldest, of multiple kids. And then it's complete lockdown. Right? And that really does play a role in bringing you or kind of shoving you into that dorsal vagal. And so we have not seen, what I observed in taking her history is she hasn't really progressed out of that yet. However, she's trying to go out and live in the world. She's trying to go to school. She's trying to do all these things.
And
The key is this is a pattern I've seen over and over and over. So, it could be teenager, early 20s. I mean, really, even someone, what I'm seeing is like 25 and older. And interestingly, that's when the prefrontal cortex is completely online in most people. That's when I'm seeing better adaptations. It's really the teenagers in the early 20s that are still having these major struggles, and for me, that was the same. That was going through high school, college, grad school, where I would go into, like, shutdown mode. I'd go into, whatever,
do you think part of
dorsal
that though
vagal.
is like life? Meaning I feel like as a male or female kinda going through this sort of transition roughly in your mid-20s is sort of like that's maybe your first real job, maybe starting to become your second real job. You're kinda
Totally, and
transitioning
if
from
it's your
college.
special interest, then you are, like, engaging in something you wanna do, and for me, I love school, but the social part of it was really stressful, and so being removed from that you're completely right, that's a huge factor in it,
And
for
I also think
sure.
like the dynamics of like, you have parents kinda helping you, you're on their insurance, you're not on your insurance, you're still probably nearish your
And then you're just
hometown.
removed and
Yeah, and then
handling
as
it.
you get
Yeah.
towards 30,
Yeah.
you start to become like
Yeah.
your own person and like
Yeah.
you're an adult child.
Mhm.
You probably have 0 financial
Mhm.
relationship with your parents anymore.
Yeah,
Like
I
you're
think
like, yeah.
that probably has to do it. So, this is a pattern I've seen over and over, okay? So, from the history, we'll see, and this isn't necessarily her, but she fit the pattern. So, not this wasn't, point for point, but in general, they will have a diagnosis of anxiety, usually a history of depression, whether that was in the past, currently, or that it has kind of come and gone. They'll be, they try to socially engage, especially the females, they will usually have friends. So with a male, they might not have friends. They might kind of be a loner, be by themselves, but a female will have friends. And really that's part of that is a survival mechanism, you know. So that's kind of my theory on, and it might not even be my theory. I probably shouldn't take credit for that, on why part of the reason why females have that better social engagement. They've kind of learned that part of it, and she can make eye contact. She's sitting there in the exam making eye contact with me, and, she's able to explain, but she's fidgety, her pupils are large, the right pupil is just blown out compared to the
And
left.
what does blown out mean?
Bigger. So her right pupil, they're like this. One pupil's bigger than the other. So the large pupils in general are going to be sympathetic. That's a stressed out system. When I see if you see someone, their pupils are really big and they're like, "Yeah, I feel great." I mean, either they're like on some sort of drugs or they're very stressed out. Slight tangent, when I used to go to all the functional neurology seminars in grad school, I, on more than one occasion, had a doctor say to me, because we'd, like, be practicing things on each other, and they'd be like, "Your pupils are so big. Are you, like, on something?" And I was always so embarrassed, and I didn't fully understand why, because 'cause I'm like, 100% no, like, that's not my style, my vibe at all. And, of course, the one fly that's in our house is, like, literally swarming me. But it was so stressful to me to be at a conference, bright lights, listening, trying to process the information, write down the information, and then have to do, like, face-to-face practicals with people. I was just super, super stressed out. So anyway, large pupils. Typically in history, you will have delayed milestones, so late to sit, late to crawl, late to
Do you
walk,
know if you
late to
had any
talk.
delayed milestones?
I don't know. I think I was, like, on the late-ish end. And let's talk about that, right? So the CDC just pushed back, I think it's the CDC, pushed back developmental milestones. They removed crawling and they pushed the rest of them back like 6 months. Like, just for the record, that is complete bullshit. These milestones are incredibly important and they mark literal milestones in brainstem and brain development. They're incredibly important. They need to be monitored. Primitive reflexes need to be monitored, all of this. So anyway, that's a big part of what I do. So, pause because the dog's gonna bark. Alright, so yeah, dog's barking. Recap. Things from the history. Typically, anxiety, depression, low motivation, hygiene issues, all of that, right? So these right brain things that we're missing, that are kind of lacking. Then upon exam, the things that I'm looking for are going to be, so I'm gonna look at handedness, and actually that's kind of an interesting thing that in our office we've really started to look at, because we have the left brain, right brain, classic, like, hemispheric profile, but handedness actually does play a role in that. So we'll look at handedness,
And what does that
eye
mean? Just
dominant,
left
which
hand,
hand?
right hand?
Left hand, right hand, yeah. And
And what's
then
like what's how do you know that? I mean, do you just ask them?
yeah, you look, so, again, a lot of the people I see are kids, so I'll hand them something, directly in front of them, see which hand they grab it with, and then I have, like, a tube, and so I'll say, "Oh, can you look through this?" And I'll see which eye they use, and then, "Oh, okay, I'm gonna tell you something," see which ear they bring to it. So those are kind of tricks if you're doing an exam, yeah. Then so I'm going to look at that, and then I'm gonna look at pupils. So pupil size, pupillary constriction, I'm gonna look at all of those factors, and I actually think this is gonna be better if I just tell you what I typically find, okay? So, typically in a right brain deficit, so I'm looking at primitive reflexes, I'm looking at vagal system, and I'm looking at hemisphericity. Those are the 3 main things I'm looking at on any patient, but especially, let's say there's this autistic female sitting in front of me. These are the things I'm looking at. Are there retained primitive reflexes? How is their vagal tone? Usually crap. And there's usually retained primitive reflexes, especially rooting, but those are usually retained. And then hemisphericity, typically, almost always a low right brain. So very strong left brain, low right brain. Okay. So in that, I'm typically going to see the right pupil is larger and the soft palate in the back of the throat, the right side is lower. So lower, that shows me vagal tone, lower on the right. Facial tone will be less tone on the right side of the face. Almost always have a right head tilt unless there's an otolith issue. And then a pyramidal distribution of weakness is going to be on the right side. We have internal rotation above T6. That just means right shoulder internally rotated, right foot typically turned out. So if they're standing in front of you, like if you stand in front of a mirror, whoever's here, if you want to stand in front of a mirror, march a few times, like, get yourself in a natural position, and most likely you'll see that that right arm is internally rotated and the right foot is externally rotated. And then you can look at the facial tone stuff as well. Primitive reflexes would be stronger on the left typically than on the right. And I mean, that's just like a quick rundown. That gives me a lot just looking at those things. And then I can do cerebellar testing and, specific lobe testing, temporal lobe, frontal lobe. I can do all of that as well. Parietal lobe is often off because, they're not feeling their body. They're not having that proper representation of their body going through. So then the cool thing about the exam is it dictates or at least gives me guidance on what is treatment going to look like. So then you do the proper things to have sensory input of the left side of the body and drive that right brain. Oh, Frank. I mean, and we can also look at like OPK would be another thing that I typically look at. So a rightward OPK is right brain, a leftward OPK is left brain. So, and then you can do vertical as well to get to check midbrain mesencephalon. Typically, I'll see within normal limits that leftward OPK looks good and that the rightward OPK will fatigue faster or be hypometric. But that's something that's really hard to check on yourself. Some of the other stuff you can kind of check on yourself, specifically the palate. Yeah.
Yeah, and I mean, how would someone check that? Literally just looking for
Yeah, you
which
just look in the back of the
and
throat.
how I mean, how differentiated are the 2 sides?
I mean, sometimes it's massive. So a lot of times, honestly, I'll see a low palate, so it's like low tone globally in the back, and then one side is lower than the other. So it's where the uvula comes down and you have like so here you have each palate and the uvula comes down. So if this side is lower, the uvula will deviate to the side with more tone. You're looking for the side that's lower, and that's the side of lower vagal tone because that's innervated by the vagus nerve. Okay, so like if I look at your face right now, right? And this is okay, so here's a story. I was out and I had someone ask me, this is so random. And they asked me, "Have you ever thought you might be autistic?" And I was interesting what's prompting that question. I'm curious, but yes, and actually I am. And I looked at them and said, "And so are you." And they were like, "What?" And I mean, come to find out, clearly, if you're asking, this is a question that they ask to everyone because they've kind of, wondered it about themselves. And I'm like, well, you have a larger right pupil, you have lower facial tone on the right. You really only use the left side of your face when you talk. You have a right head tilt, your right arm is rotated in, your right foot is like completely flared out to the side. And you talk monotone and you only want to talk about the things you want to talk about. So
I resonate with that
why
last
don't you
one.
go ahead and take these two screening tests? And they did, and they scored off the charts. So
So you were looking at me though, and you're
I was looking at you, right? And you're fairly balanced in general, but like right now you have lower tone on the right side of your face. Your right pupil is a little bit larger. Your uvula is, probably deviated. The tone in the back of your throat. And you do typically have your right shoulder rotating in, and honestly that's kind of caused you problems boxing. So this is where when I look at, autistic or not, I'm still going to look at this pyramidal distribution of weakness. And this is the same exam I do whether it's a severe brain injury in a 1-year-old or whether it's an Olympic athlete in front of me. I'm doing the same exam. I'm still trying to figure out where on this developmental trajectory are you and what needs to be worked on. So when I have an athlete, right? If you have an athlete and their shoulder is rotated in and they're trying to box, you're going to have a repetitive injury there, most likely, right? And you've had issues with
with
that
my right
shoulder,
shoulder.
right? And so what did I say? Yeah, we can work on your shoulder, but we need to do
Gotta work on your autism first.
not yours. We have to work on your brain.
Brain, yeah.
And it makes a huge difference for you in clarity, focus, and then also, in that like posture, which has not classically been your strong suit.
And I don't know if this is the right question, but like where can people go to get like a official exam like this? Is this functional neurologist? Is this only clinic or
uh, I mean,
like if you're
like
listening
let's just be real here. Like there's a reason people come to our clinic from all over the world. It just is what it is. But there are other clinics, functional neurology, specifically developmental functional neurology that will hopefully, I can't say for sure, but will hopefully look at it and kind of give you an idea.
but and
Yeah.
so those things though are physical indications of therapies that you could sort of help to address, but you're still going to be taking a neurological exam like via the testing that we talked through in the previous episode. Like you're not going to get a diagnosis through,
I'm not diagnosing anyone.
but you're just noticing deficiencies, and then those are then turned into remedies, or not remedies, but paths that you guys are doing therapies on.
Sure. Yeah. So if I'm doing an exam and I'm testing rightward OPK and that's hypometric, right? That needs improvement. So in the brain, when you want to improve an area of the brain, you fire those networks. So then rightward OPK becomes part of the treatment. That's where it comes in. You need to do it appropriately at the right time for the right duration so you don't like fatigue them because you can't create neuroplasticity in a fatigued system. You have to, you know, it's why people need to know what they're doing when they're doing this. Yeah.
Well, I think that's really helpful exam walkthroughs. Any other exams you want to talk to or any other topics you want to talk on before we wrap?
I'm going to do on the next episode, I'm going to go through like StimPod, Fisher Wallace, Mendy, Resimax, and probably Sabo as well. Like what that looks like for kind of treatment, I suppose, or like an at home regimen. Yeah.
Yeah, I think that'd be great. I think that some of the things that you've described as the at-home stuff
Mhm.
is really doesn't make any sense without seeing it.
Yeah, I agree. I
And even
agree.
seeing
We
it
need to
is
do
not
that.
100%
Mhm.
of
Mhm.
like how that all works.
Yeah.
Cool. Well,
Cool.
thanks everyone for listening. Check us out on Instagram. The
Yeah.
Autistic Female
Mhm.
is the handle.
Mhm.
Send questions, thoughts, episode ideas.
Sounds good. All right. Peace out.